Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Sidis. Glad to have everybody here today. I'm a registered nurse, been involved in urology for the past 40 years, and I really enjoy doing patient education. So here's some more education for you guys. If you're watching us on YouTube or Facebook, we come to you every Saturday at 10:30 a.m. with a new episode every week. If this is your first time joining us, be sure to check out our website at UroPatient.com, the best place to go to watch previous episodes and learn more about the show. Also, the best place to go to our download section where you can download helpful handouts that I've created for each episode. So really worth your time to go over there and check that out. This week, we're really happy to continue on with our minimally invasive therapies. And we're going to be talking about iTind therapy for BPH. Now, we've covered a group of them. We've done Resume, UroLift, and Optilume already. And this is the final one of our that's a word to try to get out, minimally invasive therapies. So we're going to do that one next. We also are lucky to have Dr. Chugtai, who's going to be joining us to talk about this, as he's the expert in this area. And we're going to bring him in right now.
All right. Well, first, thank you again for having me on the show. I'm honored. So today I'm going to talk about one of the newer BPH therapies, iTind. So as we all know, the U.S. BPH market is very large, and there's a slew of treatment options. There's everything from watchful waiting, which unfortunately I think a lot of men undergo, which they just say, hey, this is a normal part of aging, and they kind of live with this condition for a long, long time. Then we've got pharmaceuticals where we've got medicines like alpha blockers, like Flomax. We've got 5-alpha reductase inhibitors, hormonal drugs like Proscar. But we know that for a lot of patients, they discontinue these drugs pretty quickly and then kind of go, well, guess I got to live with it. We've had a surge of new minimally invasive therapies. We've had UroLift for a while, Resume for a while. Last week, a couple of weeks ago, I'm sure you've heard from my colleague, Dr. Elterman, about Optilume. We have a slew of new stents coming out, but one of the most recently FDA-approved therapies is iTind. And then, of course, we've got surgical treatment, which go from TURP to lasers to holmium lasers, a variety of cavitation surgeries, and most recently, aquablation. So what is the iTind procedure? So iTind is a new minimally invasive therapy that works with no energy delivered, no permanent foreign body. So essentially the device is implanted. We could see this over the marked areas of one, device implantation. The device is placed inside the prostatic urethra. Over the next 5 to 7 days, the device expands, creating incisions at the 12 o'clock, 5 o'clock, and 7 o'clock position. And then in 5 to 7 days, the device is completely removed, leaving nothing behind. So the device is essentially placed in the prostatic urethra in a folded configuration, and then this expands over 5 to 7 days and then completely removed. So this is just cystoscopic view. So we can see example one, where you've got this high bladder neck, right? You can see how when you're looking into the bladder from the prostatic urethra, you can see how there's no view directly into the bladder. And after removal, you can see how there's a clear channel going inside the bladder. Example two, we can see examples of these deep, deep grooves at 12 o'clock, 5 o'clock, 7 o'clock. And these relaxing grooves help the channel open up. So the iTind basically has got a couple of benefits for the physician where it's reliable. We've got 3 studies, including almost 300 patients. We have significant improvement with 50% improvement in IPSS, and we have durable results out to 3 years. What's really neat about the iTind is that you have one of the first procedures that can be done with both a flexible scope and a rigid scope. And you need minimal sedation and no special equipment. And it works for prostates up to 75 grams with no middle lobe. The patient benefit is that we have preservation of ejaculatory function, preserves continence. Patients return to daily life within a few days of removal of the device. There's very rare post-operative catheterization, no permanent implant, and all future treatment options are still open. So who is a good patient selection for this? We have people who don't want to take medications, they're not receiving enough symptom relief from the medication, side effects from medications, concerns about the risks of surgery, want to preserve ejaculatory function, and want to avoid a prolonged recovery period. And again, it's designed for men who are above the age of 50 with enlarged prostate. And from this, we can look at data all the way out to 3 years. And we can see that there's clinically and statistically significant improvement in both IPSS, which is obviously the patient-reported outcome, looking at how patients feel after a procedure, as well as the Qmax. And we can see that there's clearly a 50% drop in IPSS and a 50% patient improvement, and that lasts all the way out to 3 years. We have a Qmax improvement of about 50% as well, and that was durable out to 3 years as well. Now, when we compare the 3-year data for iTind, UroLift, Resume, what we can see is that the IPSS improvement for iTind, about 12 points, UroLift 8 points, Resume 11 points. If we look at Qmax, we have very similar improvement across the board with iTind at 7.5 cc's, UroLift at 3.5, and Resume at 3.5. Changes in PVR were pretty similar. Again, iTind at 60 cc's, 8 cc's for UroLift, and 26 cc's for Resume. And I think what's really, really important here is when we look at retreatment rate, iTind at the 1 year mark had a retreatment rate of 8.6%, UroLift about 10%, and Resume at 4.4%. When you look at postoperative catheter, I think this is where iTind really shines. We've got a 5% postoperative catheter rate, UroLift at 32%, and Resume at 90% having a catheter. So when you look at the clinical value proposition for iTind, you've got rapid symptom relief with 3 years of durability. It's got the lowest postoperative catheterization rate of all minimally invasive therapies. It preserves the sexual function, specifically ejaculatory function in men, and is suitable for those with high and tight bladder neck. And it's probably one of the first therapies that are really designed for that. And again, you're leaving nothing behind with these patients where this implant is completely removed at 5 to 7 days.
So that was a great presentation. Right now, we're going to go take a quick peek at what the surgical procedure looks like. So we have Dr. Chugtai showing a little demonstration of the procedure, give you a better idea what to expect.
All right, so here we're just doing a routine flexible cystoscopy up to the sphincter right here. And now we're going past the Vira montana. We've got lateral lobes of the prostate. We're in the bladder. Following this, local anesthetic is placed right through the scope. There's 2 purposes behind it. One is numb the lining of the bladder, and 2, to give the bladder enough room so the iTind, when it expands in the bladder, it's got space to be in there without like irritating the patient. So here's all the components that you need. Here's a flexible guide wire going inside the scope. And then here you're doing a push-pull technique to just leave the guide wire in place. And you can see how critical the nurses are for this procedure. Like, you definitely need a second set of hands. And here you put a urethral access sheath right into the right over the guide wire. And here's this collapsed iTind. And this is placed directly inside the urethral access sheath that fits right in. The urethral access sheath is then removed, and a flexible scope is in place alongside the iTind. Here, what's really helpful is having like an additional person in the room, like once, especially when you get to the prostatic urethra, just to squeeze the bag so you can get good visualization. And all you're doing is confirming, like you can see here, you're just confirming that the iTind, the portion of it that's the loop, it kind of looks like a duckbill, and it just sits distal to the bladder neck. Once you confirm that it's in position, you just remove your scope, and the procedure is complete.
Well, thanks again, Dr. Chugtai. That was a great presentation on that. So we're going to go ahead and go into our questions, our 5 H's. How is it done in the office? How much will it hurt? About a 3. How long does it take? As he said, about 5 minutes there in that demo. Recovery, 2 to 3 weeks. Now, of course, you're going to have that iTind device in there for about a week. So you have a little bit past that, probably closer to 3 weeks, counting getting the 1 week of wearing the iTind. And good results, excellent results on it. Only keep in mind there's only 3-year data because this is one of the newer procedures. As he mentioned with his anesthesia, it's like very simple. The little lidocaine jelly into the penis, as we talked about for cystoscopy in episode 5, same thing that we use in office cystoscopy. And then he adds this lidocaine solution into the bladder to make it more comfortable. And that's it. So we are finished up with our minimally invasive therapies. And next week, join us because we're going to be talking about the gold standard of prostate work, and that's called TURP. And I'm going to tell you everything you need to know about the TUR of the prostate. Thank you very much for joining us.